Thank you, Dr. Kubi. So I will give you an overview of some perspectives, some trends, both globally and in the Americas. Just a couple slides to orient what chikungunya is, where it started, how it spread, some of the drivers of the epidemic, some preparedness and response measures, some takeaway messages and recommendations. So what is chikungunya? This is one image of it here. It's an alpha virus. It's mosquito-borne, as we well know. It has manifested itself with symptoms appearing about 2 to 7 days after somebody's bitten by an infected mosquito. The symptoms are generally self-limiting and initially start for about 2 to 3 days in the acute phase, but then you can have lasting joint and pain symptoms for months, maybe years. It's rarely fatal, more so with comorbidities, and it shares, as we know, clinical signs with dengue, and that can lead to misdiagnosis where you have dengue common, which is most of our countries. So just a picture, what does it look like? These are some of the common symptoms. I'm sure most, if not all of you, are well aware of them. A lot of people raise hands to say that they have seen this before in their families. And in PAHO, we have been talking about the chikungunya epidemic as being both an arbovirus with the sort of epidemic and traits and the acute phase, as well as being an alpha virus with the more endemic phase, chronic conditions. And so there's a double impact. When you have chikungunya, you get that first acute shock, and then afterwards it comes back again to check you many times over. The same virus, not a new infection, that lingering pain and stiffness. In terms of the epidemiological cycle, there is a sylvatic cycle amongst non-human primates, rodents, birds, small mammals. I want to point out that cows are not small mammals. Some people were talking about spread in cows. And then there's crossover to the human population. It's believed initially to small rural villages, and then we had movement over to urban areas. We have been having urban cycles, and because of our travel, we've been moving from one urban area to another. Now, I include this slide to point out that in some other countries, other areas of the world actually, other than the Americas, they have been seeing the sylvatic cycle occurring during the inter-epidemic periods, and the reservoir being the monkey. And so you keep getting these epidemics occurring periodically. In the Caribbean, we do have green monkeys, St. Kitts, Barbados, and so forth, and there's not a lot that we know about chikungunya in these monkeys, and so it may be something that we need to be thinking about, a One Health approach to consider what's happening with our monkey population in the inter-epidemic periods. So where did chikungunya start? That was just a little background about it. It actually was described in 1952 in an outbreak in southern Tanzania. On our map, that's on the east coast there. And in Africa, human infections remained at relatively low levels for many years. As time went on, 1999-2000 was a very large outbreak in the Democratic Republic of Congo, another large outbreak in 2007 in Gabon, and there have been periodic outbreaks in Africa and Asia since it was first discovered in Tanzania. During the decade 2001 to 2011, a lot of countries reported outbreaks. Then chikungunya spread east to the Indian islands, to India and the islands of the Indian Ocean. The first major outbreak was early 2005, and since then, India, India, and then to the east, southeast of India, the Indian islands, other countries, and then to the southwest a little bit, you have the Maldives. Since 2005, collectively, these countries had about, it's okay, we can manage, more than 1.9 million cases. In 2006, India reported more than 1.5 million cases, and in that outbreak, it was determined that Aedes aegypti was the presumed vector. Between 2005-2006, there were more than 272,000 people infected during an outbreak in the Indian Ocean islands of Reunion and Mauritius in the sort of southwest of India. And this time, albopictus was the presumed vector. Then chikungunya spread west to Europe. In 2006, there was a peak in the number of imported cases in Europe associated with that Indian Ocean outbreak. And in 2007, for the first time, there was autochthonous transmission, I always have trouble with that word, reported in a localized outbreak in a coastal village in Italy. This confirmed that mosquito-borne outbreaks by albopictus were very plausible in Europe. This is just a pictorial. Okay. So this is showing between 2004 and 2011 the geography of chikungunya. In Africa, you see the purple that shows the West African genotype where it was, the green, the East, Central, and South Africa genotype where that was, and in Asia, you see in yellow where the Asian genotype was. The little sort of lightning strokes show local transmission. The red ones show local transmission of the Indian Ocean lineage. And you can see, that's the one I mainly want to point out, from the Indian Ocean lineage, between 2005 and 2011, there was a lot of spread. Those red or maybe actually blue arrows on your screen are showing the spread out of the Indian Ocean. And then you have some red triangles, and these are showing the imported cases in travelers. Now this was to 2011. Now what you know now is a lot of places where you see the triangles in 2011 are now where we have local transmission taking place. In the Americas, as was mentioned by one of the earlier speakers, the first lab-confirmed locally acquired cases occurred in French Saint Martin in December 2013. And it was the first documented outbreak of chikungunya with local transmission in the Americas. There was a lot of concern by countries, by agencies, about the potential spread to new Caribbean countries, given our high indices of Aedes aegypti and also our confirmed dengue transmission in 2013, so showing that the vectors were quite competent. Just to point out here in terms of the phylogenetic tree, the type that was found in St. Martin, that's circled in red here, is actually born from the lineage of the Indian Ocean one, the one that occurred in Asia. In the first half of 2004, there was spread to most of the English and Spanish Caribbean territories and countries in the Americas. In Guadeloupe, Dominica, Dominican Republic, Haiti, Jamaica, Suriname, they experienced very severe outbreaks. In the second half, there was spread south to the Andean countries in Brazil. In February of this year, we actually had cases confirmed in Bolivia and Paraguay as well. So I'm just going to go through these quickly to show how it progressed over the months. So this is the first case in the southeast of French Saint Martin in Oyster Point. This was December of 2013. Then there was some more spread to more of the French territories, and these purple dots, the size of them denote increase in numbers. The bigger dots are more numbers. Is that projecting? Okay. January, you can see now we then had spread to some additional islands, and again the dots getting bigger, more cases. More cases, more countries. You can see we have the Dutch, Aruba, French Guiana on the mainland. This is March, more and more cases. April, spread, heading towards Jamaica there. May, more countries again. June, we see now in Central America, El Salvador. July, we're starting to get we had the first case up in the US. We're having more cases south, more cases in Central America. August, dots getting bigger. September, more countries heading south, as mentioned, Brazil. And where it was before, dots getting bigger. October, more of the same. November, December, January, this is where we are now. So you can see how it quickly moved from France, it moved through the Caribbean, it moved central, it moved south, US. So right now the current situation, well in fact this is Epi week 7, so it's been a little bit of progress since then, but it's the same type of trend. This is what it looks like. The stars show where we have imported cases. So you see down in South America, and you cannot see on this graph, on this map, but Canada as well, there's imported cases, and Cuba. The dark colors show the regions where you have cases, and the light, is it showing purple or blue maybe? Blue, it's purple here. It's showing countries and regions, the different shades of blue on your screen here. But basically, the take-home message is, it's here. It's right through the Americas. It's probably a matter of time. Oh, maybe I shouldn't say that because of my reputation. But that's a picture. So as of February 20th of this year, there was local transmission confirmed in 44 countries and territories of the Americas, which as you saw is almost all. Reported to PAHO, we had over 1 million, nearly 1.25 million suspected cases, over 27,000 confirmed cases, and 183 deaths. And I point out this is reported to PAHO. We do know that there is a lot of under-reporting that is taking place because people are not necessarily showing up for care. And then imported cases in these other 5 countries. So why? Why was this outbreak so big and spread so fast? Well, first of all, the virus had not circulated in the Americas before. That would answer the question that the gentleman had posed to Dr. Hospitalis. Why do we have this thing now? We always had mosquitoes. If it's mosquitoes, why? Well, it was not here before. The virus, the mosquito was here, but the virus was not here. So there was absolutely no immunity to chikungunya. We were a completely virgin region, and so we could all be infected. Both Aedes aegypti and albopictus mosquitoes were already widespread in many areas of the Americas, and they are competent vectors. Then the amount of virus circulated in humans and mosquitoes during an outbreak, which is what we all experience, is very high. There's also within our region a high level of international travel, so that we can take along the virus with us as we go. And basically, all countries with a previous history of dengue transmission were at risk because all the dots were joined up for risk of transmission of chikungunya if you were already having dengue. So in truth and in fact, the introduction of the virus was not unexpected, not just to me, and therefore we knew that we had to prepare. And so we and partners have been working with countries in the region for several years to strengthen preparedness and response for the introduction to CHIK. Most of you are probably familiar with the guidelines that were produced in 2010 on your left, and the Preparedness and Response Plan for Chikungunya virus introduction into the Caribbean sub-region that was prepared in 2012. I had mentioned in my opening remarks about the IMS dengue, the Integrated Management Strategy for Dengue, and it has these different components. The same measures used for dengue can also be used to prevent CHIK. Of course, we don't want to keep using the same measures that don't work, but whatever we do, it's going to be a double-edged sword because whatever measures we take for one of those diseases is also going to help in the fight against the other. Very important, elimination and control of breeding sites for Aedes aegypti and protection against mosquito bites. And this strategy is not unfamiliar to the region. Many countries have implemented. In terms of response in countries, what has been happening? Well, there's been epidemiological surveillance strengthened, including syndromic surveillance and surveillance of severe cases. We know, though, this has been limited because a lot of people do not show up for healthcare when they have chikungunya. They get over that initial acute phase in 2 to 3 days. They don't let, most of them, some people don't, but most, they don't even need to go to a doctor for a medical certificate for extended leave. In addition to which, we're quite familiar with dengue. We know what we normally do for dengue, and we do the same for CHIK. So we know the surveillance is severely underreported. But it gives us an idea of trends, so it's still important, not absolute numbers, but certainly trends. Vector control activities were implemented in affected countries. They were rapidly extended to areas around the airport where people are coming in, schools, daycares, hospitals where people are congregating, and particularly ill people. Communication and social mobilization. There was information dissemination to health professionals, the public, travelers. Maybe not all the right information because we understand, we recognize that the message has not really gotten through to everybody. At the regional level, at PAHO, we've activated an event management team at headquarters. We have a network of Goan regional partners activated to monitor the chikungunya spread, some represented here, deployment of PAHO staff and Goan experts to some of the affected countries. Trainings, there's been several trainings, one on clinical awareness and case management, training in virological techniques. WHO response has been formulating evidence-based outbreak management plans. And plans really, I have been working with Brigadier Philip Spencer, and he always says a plan is not a tool for action, it's a tool for organization. The more I hear him say it, the more it makes sense to me. So we have plans, so we've been able to organize ourselves. WHO has been providing technical support and guidance to countries for effective management of both the cases and the outbreaks. Supported countries to improve the reporting systems, provided training, published guidelines and handbooks on different areas. So the takeaway messages are really that this co-circulation of dengue and chikungunya that we have is very challenging for us. It makes us open to misdiagnosis sometimes, and sometimes more severe morbidity. Chick mortality is low compared to dengue, as we probably all know, and it's mainly the patients with comorbidity that may have exacerbated disease. Chick has this double impact on our healthcare delivery. You have this first phase of acute cases, and then you have the check of a lot of chronic cases that can continue for many months, or even has been documented for years. Risk communication is key. Even using the most basic message, the chick is transmitted by mosquitoes. As Dr. Olorukuri said, if we don't recognize, understand, believe that as a population, then we don't take the steps to protect ourselves from mosquito bites, to eliminate the mosquito vector. So countries are recommended, encouraged to develop and maintain capacity to detect and confirm cases. We don't have to confirm them all, but we do need to have a sense of the trend, to manage your patients, to implement social communication strategies to reduce the presence of the mosquito vector. That's very important, and that's an area where we have a lot of work, and I hope we'll have a lot of discussion about that. To combine vector prevention and control efforts for chikungunya with those for dengue, and then we tackle two challenges at once. I would just like to acknowledge Dr. Sylvain Aldegheri, who would also have liked to have been here, especially given the weather in Washington, D.C., and members of the Communicable Diseases and Health Analysis Department of PAHO. We have Dr. Pilar, who's actually from that department, for the provision of the data for this presentation. And I thank you for your kind attention.